If you could clarify what BiPAP, how is it different from a CPAP? That's part one.
Yep. So the CPAP, what it does is it detects when you need to take air in, and it will help you take air in. The BiPAP does that, and in addition, it detects when you need to take air out, and it helps you do both, right? So the BiPAP is a little more sophisticated, and it's usually used for patients with more severe breathing problems at night.
Part two is, can you explain what RBD means?
RBD means REM behavior disorder, right? So, and REM, R-E-M, means rapid eye movement, which is the stage of the sleep when we should be completely paralyzed except for two muscles. One is the respiratory muscles, and the other is the eye movement muscles, right? And that's why, one of the features of this stage of the disease is that we are dreaming. And when you see someone sleeping in that, and is in that stage and is dreaming, you'll see how he or she is moving his or her eyes. And that's why the stage of the sleep is called REM sleep, R-E-M. And as I told you before, patients with MSA and with other neurodegenerative disorders are not paralyzed during REM sleep, and that's what it's called, REM sleep behavior disorder, RBD, right? And they act out and yell during their sleep.
So this acting out, this is much more severe than the occasional saying a word or saying a short phrase.
If you have just said a word or a short phrase occasionally, once in a blue moon, that's usually not indicative of RBD, right? What we are talking about here is consistent talking, and these dreams are usually violent or distressing for patients. So it's probably they are being chased, or they are fighting, or they are in the army, or they are in football, right? So it involves activity, and it's not infrequent that spouses get punched, so it can be very violent sometimes. But if it's just once in a blue moon, I wouldn't be concerned about that.
We have another question over here.
Yep.
I'm gonna let you ask that.
Hi, I was just wondering if you know of a drug called Riluzole. My husband was given this in the beginning, and it did help him walk. He's still on it, but I don't know if, at this point.
Yeah, Riluzole is FDA approved to treat ALS, amyotrophic lateral sclerosis, which is another neurodegenerative disease, right? As I'm telling you, Riluzole is not approved for MSA, but I don't think I think there was a small study done in Italy, if I'm not wrong, that it didn't show any efficacy in patients. And what I'm trying to tell you is that sometimes the fact that it's not FDA approved, it doesn't mean that it doesn't work. It's just that no one has really sat down and done a proper research study, right?
Yeah, at the stage he's at now, I just keep wondering if he's just loaded up with everybody hands him something. He's got a lot of medication.
But did the insurance pay for that?
Yes.
Oh,
it's
how did
very
you do that?
expensive, but they pay for it.
Okay.
But I just,
You have a great insurance. Let me tell you which one you're using.
Taking a lot of medicine beforehand. I mean, he sits there with a ton of pills every day, and
Yeah.
I'm just wondering if one of them should be eliminated. Thank you.
Yep.
Okay, we have another question over here.
I'm just wondering if a patient is bedridden, toward end stage, would that patient still benefit from levodopa, carbidopa, and midodrine and fluorocortisone like 3 times a day?
Right.
No resting tremor?
I understand. So remember, these are all symptomatic treatments, meaning these medications, they are not a cure. They are not going to change the progression of the disease. So they are intended to make the patient's life easier. So the patient usually is the one answering those questions, right? Is the levodopa, is the Sinemet making my tremors less severe or making my movement less troublesome? If it's a yes, some patients tell me, Dr. Palma, I know it's not doing much, but I still want to keep taking it. Some other patients tell me, Dr. Palma, I don't think it's doing anything. And I tell them, stop it, right? So if you don't need to take it. Can you do that? Can you try it to stop it? Anytime. Yeah, you can stop it for 1 week, 2 weeks, see if there is any effect. And if there was any effect, you can go back. I mean, this is not like surgery. You can be back and
I was curious about the mitogen because it's
Right.
it's the highest dose, 10 milligrams, and if the patient is lying down, I didn't think the drop in the pressure.
I agree with you. I agree with you. So if a patient,
Is it just being given for, and not having really, doing anything?
if a patient is lying down in bed all the time, he or she is not going to have a drop in blood pressure, right? Because he's not standing up anymore. That's what Mitodrine is used for, is to avoid the drop in blood pressure. So I don't know the patient, it's not my patient, but I will assume that if he or she is flat all the time, his blood pressure is going to be relatively stable, so he probably doesn't need, or she doesn't probably need Mitodrine. The same, right? But again, in general terms, right?
So my mom seems to be on this horrible treadmill where it's like she gets a urinary tract infection every 3 to 4 weeks or so, and she is why can't I pronounce that word?
Catheterizing.
Catheterizing. And still, that was the initial solution, but it's still happening. And so what we wind up doing, and she has like another one now, it's like she takes the medication, she takes antibiotics, and that makes her feel weaker. And then it seems to work
Right.
for 3 weeks or so, and then she gets yet another, and it's just like, and then the antibiotics, and it's like this horrible cycle. And I'm wondering if there's anything that you've come across. I mean, I'm trying to think of,
How many times does she self-catheterize a day, more or less? Is it like once
like,
or 6?
no, I think like 3.
Like 3, okay.
Yeah.
Look, I'm sorry to hear that. Sounds like a very challenging situation, right? So what we tell patients is, of course, I'm assuming the technique of the catheter is as clean as possible. The catheters are, you know what I mean, right? And then it's very important to ensure that when you use the catheter, the bladder is completely empty. Because if there is some residual urine in there, it's like the catheter did nothing. And that's what bacteria love, Bacteria love a humid and warm environment. So if there is any residual urine, that's great for bacteria. So I will tell you that. Number one is to make sure that when she uses the catheter, the bladder is completely empty, right? So take the time, a few minutes in the bathroom, make sure everything that can come out does come out. Then some of the people require, instead of 2 or 3 times, maybe they require more time, right? Again, I'm assuming that the catheters, that the technique is done properly with washing hands, etc., etc. Then, what you were saying, some patients still require chronic antibiotics, right, to prevent the infections. And most patients do more or less well with that, right? And the thing is to find the proper antibiotic to make sure that the bacteria that you are killing is being killed by the right antibiotic, right? And then eventually, some patients are not doing well with any of these, and what we do is we just do a suprapubic catheter, right? Just to release them from the hassle of catheterizing and make sure that the urine is coming out properly. And some of them still require antibiotics, both of them, right? The suprapubic catheter and the antibiotics. But I hear you, because that's some of the most bothersome problems in MSA, the urinary infections. And that's some of the cause of death. It's the infection itself that can spread to the body and cause sepsis, right? So I know some patients are concerned about the movement, some patients are concerned about the tremors, but what's gonna kill them, it's the infections, right? So that's a very, very important piece of the treatment plan.
What is standardized autonomic testing? Yep.
Some centers with a dedicated autonomic clinic have the technology and the expertise to do standardized autonomic testing. And what we do is just to confirm that the blood pressure problems are actually due to damage in the autonomic nervous system, in the nerves, right? Because, for instance, some people have low blood pressure when they stand up, but this is not because they have MSA. This is not because they have a problem in their nerves. It's because they are maybe a little dehydrated, or they are maybe a little anemic, or they have huge varicose veins, right? So we do this testing, this standardized autonomic testing, to really confirm that the autonomic problem, that the blood pressure problems are due to problems in the nerves. And what it entails, it's basically a tilt table test, which is you put patients flat for a while, you measure the blood pressure, the heart rate, and then the table is gonna tilt upwards so that the patient doesn't move, and then you measure the blood pressure and heart rate again for a few minutes. And then there is another number of breathing exercises that we do to see how the blood pressure and heart rate change during these exercises. And we can always measure the hormones in the blood that are involved in blood pressure control, right? They're like norepinephrine, epinephrine. So we can measure all that. And again, it's all to confirm that the blood pressure problems in the patients are because a neurological problem and not because other treatable problems, right?
Okay, we have time for just a couple more questions. We have
Yep.
one over here.
Could you speak to muscle pain that's caused by MSA? What are the causes? What are the treatments? And
Yep.
do you have any success with marijuana?
The muscle pain is mostly because of the rigidity and that the movement disorder causes, right? Some patients can get cramps, some patients get curly toes, some patients can get rotator cuff injuries, quote unquote, because when they go to the doctors, they are diagnosed with that. But it's not actually a rotator cuff, it's just the rigidity in the joint, right? Then the fact that most patients have trouble with movement, that they don't move, is like a vicious cycle, right? So of course they don't move because they have this movement problem, but not moving makes everything worse. The muscle pain is worse, the joint pain is worse, right? So it's a combination of all these circumstances. It's not that the disease affects the muscle, it doesn't. It's not that the disease affects the joints, it doesn't. But the rigidity itself, the nervous system related rigidity and movement problem may cause this pain, right? Medical marijuana. Medical marijuana, we could speak for hours about medical marijuana, right? And because now there are so many different types, right? You have the weed, you have the THC, which is one of the compounds of the marijuana. You have the CBD, which is another compound of the marijuana, right? And each of these have different effects, right? I can tell you from experience from a few of my patients. This is not a research study. This is not published. It's just anecdotal evidence. I can tell you. Patients tell me, okay, Dr. Palma, this is what I feel. I feel that it's not helping for my movement at all. It's not helping for my blood pressure. It can sometimes even worsen the blood pressure. It can drop the blood pressure. When I'm a little high, I'm a little less depressed, and I'm a little happier, so it's helping for that. And some patients with insomnia, some patients can have some benefit from that because they help them sleep. For the pain, I'm not sure. I mean, if a patient is a little high when they are having the medical marijuana, you assume that they are feeling less pain. So it may help, but again, I don't have scientific information, I don't have solid data, and you should the one telling me at the end, how do you think that the medical marijuana is helping if your beloved one has tried it, right?
Okay, we have another question over here.
Well, first of all, I'd like to commend Dr. Palma on finding my high cholesterol in one of his tests. My mother lost 4 boys to heart attacks. But my question for you now is, do the symptoms of PD appear in MSAC? And also, is there like an increase in sleep problems? I had an overnight sleep test. Do I need another one? That's my questions.
Yep. So answering your question, I would say yes, eventually every patient with MSAC will develop some degree of Parkinsonian-like symptoms, but sometimes it's very in advanced stages, right? So it's, again, very advanced, and some patients may have the cerebellar type for most of the time, but also vice versa, right? Most patients with MSAP eventually develop cerebellar types in problems, right? And again, it can be very late in the disease progress, in the progress of the disease. So your sleep problems. What we usually recommend is let's say you had a sleep study and everything was fine, perfect. So what we are gonna do is we're gonna reassure you for a few years, but then if you tell me, you know, Dr. Palma, I'm snoring more than before, or when I wake up, I'm not as refreshed as before, I may tell you, you know, you may need another sleep study, but it's gonna be, I mean, every couple of years, every 3 years. So answering your question, the fact that your sleep study was completely normal now doesn't mean that it's gonna be normal in a few years, right? So for which we may need to repeat it.
Okay, we have one final question over here.
I know the trials that you showed today, some of the requirements were being able to take some steps and walk. Are there any trials for those that are interested in a trial that are wheelchair bound?
The blood pressure trial doesn't require anything in terms of movement, right? So if he has any significant problems with blood pressure, he will be eligible for that one. The other one that we have right now requires some degree of being able to walk with help. That's the two major ones we have right now. The other two companies I showed at the beginning that they say, oh, the breakthrough therapy, whatever, they haven't started clinical trials. They will within 6 months, 1 year. We will be part of those trials too. And I'll let you know. I don't know exactly which inclusion criteria are, but definitely if they allow patients that are advanced in terms of movement, that are wheelchair bound, you'll be the first to know.
Okay, and I lied, we have one more, and then we will wrap up and take a break for lunch.
So I want to find out if there any medication for involuntary movements. Like my husband is in the advanced stage now, and lately he's been sticking his tongue like uncontrollably, and then he gets tremors.
Right. But is he taking any Cinemed or any levodopa? Because sometimes
Doesn't
that's
do anything for him. No.
right.
Rasagiline.
Rasagiline, do you think is helping?
I don't see any
I mean, there is
difference.
there is a number of medications that are used for patients with Parkinson's, right? You have the levodopa, the rasagiline. Some people are taking amantadine. Some people are taking Nupro, which is a patch. Some people are taking pramipexole. Again, in some patients work and in some patients doesn't work, right? So that's something that you may have to talk with a neurologist and trial and error. Exactly. But unfortunately, I don't have like a perfect medication for every single patient, right? That's something that unfortunately we don't have yet.
Okay, thank you, Dr. Palmer.
My pleasure.
Palma, Dr. Norcliffe.